Welcome to session 2, and in this session I'm going to teach you how to review systematically the 12-lead ECG or EKG. You know, it's very important, however fast you become at this skill, that you do review systematically, so you don't just focus in on the more obvious abnormalities. There's a lot of resources out there now, books, online, colleagues and so forth, so do utilise these to keep practising the skill. It's very important. First of all, ensure that the tracing has been recorded accurately. If you're in any doubt, re-record. Make sure you have a clean trace, that is, that the lines are sharp and clear and the complexes progress horizontally across the tracing. Issues of thickened lines, wavy lines and so forth should be sorted at the point of recording. Check your calibration exactly as we've described. You must see 25 millimeters per second printed on the tracing, and also the box calibration on the far left must equate to 2 large squares high. Again, very important. Look then at lead 2 or the rhythm strip. You might not have a rhythm strip, but it's important to look at that because that's quite a long tracing and it normally is lead 2. Not always, but normally is. You're looking to see that the patient is in sinus rhythm. Now sometimes I have students who desperately look for one single P wave and presume that everything is in sinus rhythm. Certainly if one lead is in sinus rhythm, they all will be. But do take time to look at the rhythm strip or lead 2, a number of complexes and a number of leads if you can, to reassure yourself that they are in sinus rhythm. Measure the PR interval. As you now know, it has to be no wider than 3 to 5 small squares. If it's consistently longer, this is suggestive of first-degree heart block. As we said, check there is 1 P wave per QRS complex. If there is more, this is serious. It could be second or third degree heart block. And this is worrying because the atrioventricular or AV node is now unreliable in its ability to conduct P waves through to the ventricles, and this needs further investigation. Look at your QRS complex, both the width and the shape. Again, as you now know, it should be no wider, it can be on, but no wider than 3 small squares, and should be a consistently sharp shape. And here's a useful tip for you. If the QRS complex is narrow, it's highly likely to be an atrial arrhythmia. Of course, sinus rhythm will also give you a narrow QRS complex. Now this is because the ventricles say, as long as depolarization travels down the normal pathway in the ventricles, however it's occurring in the atria, we will give you a normal QRS complex. So we think of atrial fibrillation, supraventricular tachycardia, sinus bradycardia, all the atrial arrhythmias will give you a normal QRS complex. Conversely, if the QRS complex is wide, it's highly likely that you have a ventricular problem or a ventricular arrhythmia. There are, of course, exceptions to this. You might have sinus rhythm with a widened QRS if, for example, there was left or right bundle branch block. But as a general rule, it's highly useful. A narrow complex QRS is generally an atrial arrhythmia. A broad QRS is generally a ventricular arrhythmia. Next, you need to calculate the heart rate. Remember, of course, check that the tracing is regular to start with. You know how to do this now. Place a piece of paper over the 12-lead ECG or EKG, mark off 2 R waves, move the piece of paper along, and subsequent R waves should fit over those marks. If it's irregular, it's suggestive of atrial fibrillation. But if it's regular, count the number of large squares or part of between one R wave and the next R wave, or the same point on 2 adjacent complexes. And divide that figure into 300, even if it's a part of a large square. So it might be 4 large squares or 5 large squares, or it might be 4.5 or 2.2, whatever. Divide it into 300. If it's irregular, I've told you what I suggest, and the different ways of doing this. Count 30 large squares and the number of R waves within that 30 large square period, and times that by 10. It just picks up a little more of the irregularity. But really it's best to take the patient's pulse for a full minute, and as I said before, you'll gain a lot more by feeling the pulse, character, strength of pulse and so forth. And finally, look at the leads. Divide this in 2. Look at the limb leads, that's on the left of the tracing, and look at the chest leads on the right. Now when you look at the limb leads, consider the cardiac access and consider that diagram, that adapted form, the hexaxial reference system that I drew for you. And you can draw that on a piece of paper or the back of the ECG or EKG. But remember that AVR or VR is very negative, with an inverted P wave and T wave, and a short R wave and a deep S wave, while its mirror image or opposite number lead 2 is very upright. Now don't worry if leads 1 or lead 3 are slightly taller or more upright than lead 2. The cardiac access does swing in differing people slightly to the left or slightly to the right. Hopefully lead 2 will be the tallest, but it's not always the case. When the cardiac access swings significantly to the left or the right, we call that left axis deviation or right axis deviation. I'm not going to cover that in this workshop, but I've introduced the terms to you, so you might like to look those up. And then look at the chest leads. We're looking at V1 or C1 through to V6 or C6, and they should progress, as we've explained, from negative through to positive. Once you've done that, you can start picking out the abnormalities amongst the tracing. Now to do this, we're going to move on to session 3, and we're going to use this systematic approach to look at some abnormalities on 12-lead ECGs or EKGs. You may want to replay this session until you're comfortable with the principles we've gone through. And remember, always use the 12-lead ECG or EKG as part of a wider holistic assessment. When you're ready, I'll see you in session 3.